Good evening, everybody. My name is Timothy Young. I'm a communication specialist with the Fair Chance Criminal Justice Project of the North Carolina Justice Center, and I want to welcome you to Decarcerate Now NC's Community Conversation series. Today's community conversation, right now, this is our third in the series on incarceration as a public health issue. The Decarcerate Now NC Coalition continues their fourth annual vigil outside the governor's executive mansion, showing solidarity with more than the 30,000 people currently incarcerated in North Carolina's jails and prisons. The effort has built up momentum with support from organizations and community members across the state. And so the Vigil for Freedom, Racial Justice is a demonstration, a call to action, and a public platform outside the NC Executive Mansion, comprised of a regular rotating group of people and organizations with the primary demand that Governor Roy Cooper uses clemency power and all other means to decarcerate North Carolina immediately. To learn more about our efforts, you can learn more at decarceratenownc.org. Also this weekend, I want to plug that our coalition is holding two community events outside the governor's mansion this weekend. Friday at 1 p.m. and Saturday at 1 p.m. Friday is our Freedom Friday. We'll be having an open community event where members of the community can hold vigil for themselves and their loved ones who are justice impacted. On Saturday, we're going to be holding a free James Richardson holiday rally where advocates and community members will gather in solidarity and shed light on the wrongful incarceration of James Richardson, as well as others who are raising awareness about the broader issue of wrongful convictions and the plight of incarcerated people in North Carolina. So I'm going to turn it over to my colleague, Keisha Millett. Thank you so much.
Good evening. Thank you all for joining us for another community conversation. I have the pleasure of introducing our speakers. We have Dr. Lauren Brinkley Rubenstein, who is an associate professor in the Department of Population Health Sciences at Duke University School of Medicine. She is a national expert in examining how the criminal legal system impacts people, families, and communities. During the pandemic, she co-founded the COVID Prison Project, one of the only national data projects that tracks and analyzes COVID testing, cases, and deaths in prison systems across the country. Her work blends research and policy, which has recently culminated in providing expert consultation to Congress relevant to prison standards and data reporting. I'd like to also introduce Dr. Craig Waleed. Dr. Waleed is an educator, counselor, certified restorative practices group facilitator, published author, and motivational speaker who is passionate about using higher education to disrupt the community to prison pipeline and reduce post-incarceration recidivism. He currently serves as project manager for Unlock the Box campaign against solitary confinement for Disability Rights North Carolina. Dr. Waleed has worked on various projects aimed at empowering formerly incarcerated people. These include podcast interviews, a TED Talk, panel discussions, workshops, mentoring, and coaching. He also has a published autobiography and a recently published book of poetry. Dr. Evan Ashkin is professor of family medicine at the UNC School of Medicine. He teaches in the underserved track of UNC Family Medicine's residency program, as well as sees patients at Piedmont Health Services, which serves vulnerable populations. Dr. Ashkin also founded the North Carolina Formerly Incarcerated Transition NC FIT program to help chronically ill former prisoners who have recently been released connect with primary care medical services that they can access regularly. Most recently, Dr. Ashkin helped establish the North Carolina Technical Assistance Center, which is a statewide initiative to provide technical assistance to programs that support individuals at risk of incarceration and overdose. Please join me in welcoming our speakers. Thank you all for being with us this evening. I would like to start first with Dr. Rubenstein. Could you provide for us an overview of what people are experiencing in prisons and jails, and generally about the public health impacts of incarceration in North Carolina?
Great. Thank you so much for having me. I'm going to give a broad overview, and then I hope Craig and Evan will be able to add to that and talk about some of the work that they're doing to ameliorate some of the harms of the carceral system, both in the state and in the country in general. As maybe a an important thing to know about me is that I'm trained as a community psychologist. There aren't that many of us. And so I don't know, I've never met another one who does this work. It's really based in the social ecological model. And if you've probably seen this before, it's people nested in families and communities bounded by important contextual factors like geography, thinking about time and policy. And all of that is really to say that the way that I think about mass or hyper incarceration is that it is cross-cutting in its impacts, impacting people, families, and communities. And it looks different depending on the facility you're in, whether that be a jail or a prison, whether it be here in Durham or somewhere in a more rural community. And so the impacts may look a little different depending on the different types of exposures that you might have. But the net truth, the real thing that is undeniable is that any amount of time spent in a jail or prison is bad for your health. It's bad for the health of the people that you love and that love you. It's bad for communities where that are over-policed and over-incarcerated. And as we all know, those tend to be communities of color. And so incarceration itself is a very integral facet of structural racism in this country, and it is something that is undeniable. And if anyone ever tries to talk about incarceration and doesn't talk about structural racism as the overlay of a hyper incarceration, then that's not a person that should really be trusted on this topic. And when it comes to public health, I think that in some ways, the connection between incarceration and public health in scholarly spaces is kind of new. And in some ways that's a disappointment, right? When you think about big public health thinkers, when you think about big public health schools, they tend to be pretty disconnected from the community and what community knows. But there is this burgeoning understanding that public health is impacted by incarceration, and in large part, that's because of the COVID-19 pandemic, for better or worse. Our group started, as Keisha mentioned, the COVID Prison Project, which was one of the only national aggregators of the COVID cases, COVID deaths, COVID testing in carceral facilities across the country. And we did that. It started as a spreadsheet and grew into a national project because we knew that these spaces are spaces of risk. They are spaces that endanger people's health. They're tend to be overcrowded on average. They tend to not be well ventilated, and healthcare infrastructure is often non-existent. And so when you've got a lot of people in close quarters who, and there's not enough staffing or infrastructure to provide healthcare, it really is a perfect storm for what we saw across the country, which was mass devastation, mass death, mass impact on people who were incarcerated, and a deep connection between cases that were in jails and prisons and community. And so I think that helped to really underscore that there is this connection between jails and prisons and public health, and that public health really ought to pull a seat up to the table and start to think about people who are incarcerated as important, and as within their purview to think about providing healthcare, providing interventions to address health, to make people more well after they get out, and also to really take up the case of abolition. Important to note that in my work, we do a lot of sort of very traditionally funded National Institutes of Health work that focuses on very discrete health outcomes, also really tending to focus on conditions of confinement. But we use that evidence in these more individual micro studies to move toward building evidence for big paradigm shift, to think about how do we use evidence of the harms of the carceral system to move into abolition, to move into alternatives to incarceration, to reduce the population of people that are exposed to this setting. And I think any public health intervention that tries to better the health of folks who are incarcerated is good. It's somewhere to start. But if they stop there, then it really is not doing enough. I think most public health interventions really have to think about how do we move outside of the system, get rid of the system, and move toward community practice, community wellness, community interventions. Yeah, I think I might leave it there and then turn it over. I think, is Craig going to go next? And Craig can talk about some of the awesome work that he's been doing in the community in Durham.
And I'll hand it over to you. We know, Craig, that much of your work is focused on solitary confinement, and you are leading a campaign around that. If you could help us understand how that is also a public health issue and other information you think would be helpful for us to hear.
Yeah, absolutely. Can you hear me clearly? Yeah,
Yes, sir.
okay, great.
Yes.
Well, thank you for inviting me to speak, and thank you for validating my perspective around these things. But first, I'd just like to say that I come to this work as a survivor of solitary confinement. I spent two separate terms of 30-day terms in solitary confinement while doing an 8-year sentence, or actually doing 8 years on a 12-year sentence in New York State's prisons. This December will make 26 years that I've been out. So it's been a long time since I've been out, but the impact of solitary confinement and incarceration continues to impact me all this time later. And so this is the lens that I see it through. But at the same time, we can't deny that what solitary confinement is it's the physical isolation, excuse me, of an individual. They're physically confined to a cell for most of the day, maybe 22 to 24 hours a day, most days. But solitary confinement, in many systems, particularly here in North Carolina, we might hear different names. They may say we don't have solitary confinement. Instead, we have restrictive housing or segregated housing or the whole, or you might hear isolation or lockdown, and there's lots of other different names. But thing about solitary confinement is because it isolates people and keeps them away from having any type of meaningful communication or contact with other human beings. It causes, I think, a deterioration of their psychological and emotional faculties. At the same time, because of the environment in which they are forced to live in, and eat in and sleep in and use the toilet in, is such a very small space. It equates to that, along with being inside there for 22, 24 hours, as torture. And the space is typically maybe 6 by 8, about the size of, I don't know, a parking space, maybe, where you would park your car, or maybe a small bathroom in an apartment. So imagine trying to live in your bathroom and you can't open the door. You don't have a phone or a book or anything. And instead of having a shower there, that's a bunk. And you only can come out a couple of times a day or a week to take a shower. But at any rate, solitary confinement cells, people don't have windows, all types of things. I can go on and on. But at the end of the day, sometimes people spend days, weeks, months, years. And I think there was one person who spent, I think the brother Albert Woodfox, he recently died. I think he was released in like 2016 or something, after serving like 40 years in solitary confinement. So people are in there for a long time, and it causes again, a deterioration of people's psychological, emotional faculties. And so, and I'll wrap it up because I don't want to keep going. But here in North Carolina, we have probably about 2,500 to 3,000 people living in solitary confinement or restrictive housing a day, and people who live in solitary confinement, typically, I think Lauren mentioned, who spent any amount of time in jail or solitary confinement or prison, have an increased rate of having poor health outcomes. I think I'm paraphrasing her, and correct me if I'm wrong, but at any rate, I think some of our statistics show that people who have been in solitary confinement are maybe 78% more likely to die from suicide in the first year after release. And then again, they're at 50 or maybe 60% more likely to die from homicide after release. And then the numbers are out of the roof for dying from opioid overdose. It's like over 120% to die for opioid overdose in the first 2 weeks after release. These are people who have been exposed to solitary confinement. And then, I'll just bring it in a little bit and finally talk about how, solitary confinement, because people oftentimes have psychological, mental, physical health issues, they then are released back into the community, sometimes untreated or with very little treatment, and they become a cost to the healthcare system. They also become maybe a detriment of spreading communicable diseases, because people who are incarcerated sometimes have increased risk of carrying communicable diseases. But also, it's a burden on taxpayers. The financial burden of maintaining the solitary confinement facilities costs a whole lot more than it costs to maintain, say, a regular general population facility. So I think that at the end of the day, solitary confinement needs to be abolished, because that's really what we are trying to do with the work that I'm doing with In Solitary NC, which is part of Unlock the Box, where we're running a campaign here in North Carolina to end solitary confinement in the prisons here. And so we are doing community activities to raise awareness around this activity or this practice, because we see it as torture, which is what the Mandela rules. I can go on and on. I don't want to hog the mic, so I just want to pass it to Evan right now. And if people want to ask other questions, I'll take it from there.
Thank you for sharing about your experience and providing an overview. And I think we will have some time to get into more discussion later as well. Dr. Ashkin, through the Formerly Incarcerated Transitions Program, you work alongside community health workers who have a prior history of incarceration to support folks in their transition from prison to reentry. Could you share some of the key components of your work and why it is so important to focus on health during this transition period?
Yeah. Thanks, Keisha. And it's really nice to be with you all and be here with Craig and Lauren. And I do just want to reflect on, I think, one thing that each of those, my colleagues said. So Craig, I mean, this post-incarceration syndrome is incredibly real. And I think prevalent doesn't even get to it. Actually, I was seeing patients today in this FIT program who were all formerly incarcerated, and definitely saw a guy today who one of our newer patients, and without a doubt, had a period of solitary confinement that he is really struggling from. And we know very little about it, like most things that have to do with incarceration and health, and what and how we can try to ameliorate those harms. And then I just want to reflect on what Lauren was saying, in that the more meta issue that our carceral system really drives health disparities, like period, in the US, and that we will never significantly impact health disparities, especially racial health disparities, without dismantling the carceral system. And that otherwise we're just putting band-aids, we're that public health analogy, pulling babies out of the river. We will keep doing that. Because we will keep creating these harms through the perpetuation of mass incarceration that keeps driving ill health and poverty in communities of color. The FIT program, Formerly Incarcerated Transition Program, I take zero credit for the model. What I take credit for is recognizing this was a good model, that as a physician, seeing people who fell into this terrible abyss post-release of, lack of many reentry services, but the House of Medicine has been absent. I mean, significantly absent from care of people who were in the carceral system and then post-release. And without some type of compassionate, appropriate response, even if you provide people with health insurance, it doesn't change. And I really want to make that clear, because yes, we're expanding Medicaid. That's a lovely thing. It is that in and of itself will not change this issue. And there are a number of studies that have shown this throughout the country. Actually, recently, a study published by some of our colleagues showed that people who suffer from mental illness and substance use disorder in states that expanded Medicaid did not have any measurable increase in their access of treatment for mental health and substance use disorders in states that expanded the ACA, Affordable Care Act. So our program is based on hiring people that are formerly incarcerated and doing special training as community health workers to help them be more effective in a role as sort of like a peer navigator. But importantly, it's not just that. The folks, Shira Shavit and Emily Wong, who put this model together after doing focus groups with people who were incarcerated at San Quentin, clearly also understood that this was about centering the voice of people impacted in this work, which is also very uncommon, as I think we all know, in our academic health centers, but really throughout our health systems. We tend to think, oh, we have this knowledge, now we need to go impart it on people and their health will improve somehow. And this model is very subversive in that it takes the opposite approach, that the experts are the people that are impacted, and that we need to give them the opportunity to have their voice heard and recognized. And so we try to, our community health workers are fit. That is what the FIT program is. And all of our research meetings and our when we talk about, what our next steps are and how do we expand and what kind of questions are we going to ask people, it's all driven by the expertise of people that have been there. Our model, as I stated, so we hire folks formerly incarcerated and then try to find a medical home, which is in our state pretty much exclusively federally qualified health centers that carries the same mission of trying to ameliorate the harms of our inequitable society. And the good news is we have amazing FQHCs in this state. I think one of the results of a state that is so poorly funded for health service that didn't expand Medicaid, where you struggle, is that no one is in this business unless they're in it for the mission. I mean, you don't decide to run a federally qualified health center because you think you're going to rake in the bucks from some margin. It is the opposite. You are struggling to keep the lights on. So we have I've been really, really pleased with the embrace, I would really say, of this model, and people also understanding that to be part of our FIT program means to have that humility, that you don't think you know the answers, but that you want to be an ally and a community member to try and lean into this work. So we started actually in Durham in 2017. We've expanded our network out to really 7 now, and we're pretty much in all the population centers, but woefully inadequate. I mean, our community health workers, it's super high touch. So this isn't someone who's making a referral and telling you, oh, go to this appointment or do this. It is meeting someone at the gate when they come out, putting a cell phone in their hand with minutes on it. It is taking them to their appointment, sitting there with the provider, helping to interpret that visit, get them, make sure they have their meds. Now we need to go down to DMV and get your ID, or we need to send a letter to Ohio to get a birth certificate to do this. So on all these, the really hard work of reintegration, reunification with family. So it's very comprehensive, what our CHWs do, but the real difference is they are embedded in a community health center, and we support the sliding scale fee for those visits and for their medications. But sadly, we still really haven't meaningfully expanded Medicaid. Hopefully it's coming, but, people have still been unable to access specialty services, imaging, all kinds of specialty meds. You have multiple sclerosis, you have significant mental illness, all these, significant barriers still. So I don't want to sugarcoat that we have been able to solve these problems, but we are able to at least connect someone with someone who has been there. And I can tell you that and as we said before, the disproportionate impact on communities of color, actually almost all of our 20 community health workers are people of color. So they are able to have that race concordance, which, as we know from healthcare studies, is essential if you're going to improve outcomes for people that, we're caring for them, can share that background as well. So, that's what we're about. We do a ton of work around the opioid epidemic because quickly we learned that so many people, they're incarcerated for the crime of being mentally ill or the crime of having substance use disorder, which are both treatable issues, right? And over half the people in our carceral system are there for those two crimes and, minor crime related around having those diseases, and we can effectively treat them. So we've gotten very involved in providing Suboxone, which is buprenorphine, which is a highly effective medication for opioid use disorder, is the gold standard for reducing death post-release, and up to 85% of reduction in post-release overdose death that Craig mentioned earlier, if you get people started and then continue. So we've worked with the prison system to help that pilot start and then with local jails so people get that effective treatment. They're not taking off it and they can continue. So that's sort of what we're about, what our model is. And I do just want to take one last second to plug our Technical Assistance Center, which is now open to all 100 counties. We partner with the North Carolina Harm Reduction Coalition, which, as you hopefully all know, has tons of people with lived experience that really know their work. And then with the Duke Opioid Collaboratory to help with evaluation of programs. So I'm now going to pass it back. Thank you.
Thank you so much. And I'm hoping to just follow up with all three of you. Actually, before I ask another question, you all have shared so much. I just wonder if you have any additional reflections or anything you think would be helpful to highlight from what another person has stated.
I think there was a couple other things that maybe I didn't mention much, and that is about some of our advocacy work that I'm working on, where I'm managing the campaign against solitary confinement. I did say something about it, but I just wanted to let folks know that we're looking always for people to join us in this advocacy work. And right now we are a coalition of stakeholders from across the state of North Carolina, and we're growing, and we meet pretty much every other month on ways to strategize on getting some sort of policy change or eventually some sort of legislative changes coming maybe way down the line. But right now we do a lot of community education around solitary confinement because, again, we want to see it end. And so, yeah, just please give us a check us out. Maybe come to our website at Disability Rights North Carolina, see what we're doing. Reach out to me so I can tell you more about it. Because like I said earlier, I can go on and on, but at the end of the day, our work is aimed at trying to dismantle the system of solitary confinement.
Yeah, maybe I'll just add to that a little bit. I mean, the major goal, I think, for all three of us is really to create big paradigm shift to figure out how to not have prisons and jails. Solitary confinement is one of these things that in some ways is a lever that can be pulled now that can create better conditions inside while we move toward this bigger change, because it is internationally defined as torture. The United Nations has put forward the Mandela rules, which says that it should not be used. And if you do use it, that you should never use it for more than 2 consecutive weeks. And the paper that I linked in the chat looks at that. So if we look at time and we look at this Mandela rule definition of solitary confinement, and really found that 1 minute spent in solitary confinement increases the risk of death post-release. And that risk increases as I saw somebody also put in the chat, the more time you spend, the higher the risk. And the multiple times, so if you go to solitary, come out, go back to solitary, come out. So the more times you're in solitary also increases the risk. I will say that paper is one of the most impactful things that I think my group has ever done. It's cited in a Supreme Court case that was not successful, but went to the Supreme Court. The minute it was published in North Carolina, it's based on North Carolina data. The ACLU sued the prison system, also unsuccessful, but it has in other states that are more progressive led to some change where they don't use solitary confinement, or they only use it abiding by those Mandela rules. And so there are pathways to change, and solitary is such a great example of something that so clearly needs to be abolished.
Thank you so much. I think we will go ahead and transition to our breakout rooms now, so we'll have time for conversation. Just want to say for everyone on the call that I am seeing that we have a mix of advocates, of folks who work in health and practice law and reentry, and also writers and or journalists. So I think we are up for a really interesting conversation. I wanted to just take a moment and folks could kind of bring back some initial reflections from our conversation. I would love to, if it's okay, to see if our panelists would be either interested in offering a note, and then see if there are other comments that folks have. So I'll start with you, Dr. Brinkley Rubenstein.
Okay, great. Yeah, we had a great conversation. Some things that I wrote down is really being able to understand how exposure to jails and prisons creates and exacerbates health conditions. We particularly focused also on mental health and thinking about how the trauma that people experience in these systems worsens existing mental health conditions, and the need for to really just understand how that works. And so talked a little bit about 1115 waivers, which Evan and I have been thinking about a lot, which for everybody else is this new thing that a bunch of states have applied for, which allows the federal government to pay for the care of people who are incarcerated in the 90 days leading up to release. And so it also creates systems where you can get data, right? If you're doing a Medicare or Medicaid claim via that waiver, then you have to report that to the federal government, and then people can get their hands on it and can kind of see what is happening, what is the scope of care, what's the scope of diagnosis, what's the scope of what's not happening inside. So maybe an opportunity to hold facilities more accountable. We also talked about the importance of linkage post-release, and then talked some about the need to strengthen the connection between policy to practice. So you might get research to policy, but policy to practice, how does that work? And how do you keep systems accountable? And how do you make sure that they're doing what the policy states they should be doing? Thanks.
Thank you. Dr. Wali?
Yeah, hi. We talked about quite a few things. I don't think I took as good of notes as I should have, but some of the things that I think that really grabbed my attention right off was that we talked about the importance of the need to focus on women's health in prison. There needs to be greater emphasis on that. Though there's been some legislation around that, there still needs to be more emphasis on women's health. But at the same time, I think, and we didn't touch on this, but I think we kind of went around the edges of it. I think decarceration would really help with a lot of these things when it comes to working on prisons issues. But also, Daquan Peters, he talked about, and we got into a robust conversation about the importance of having community mental health treatment available for all people who are getting out of prison, no matter how much time they've done. If they don't want it, they don't want it, but it should be available for them. But at the same time, I didn't mention this in our conversation, but I think it should be quality care, because again, like in prisons, people are getting care, but the care is not quality care because people continue to have poor outcomes when they're in prisons, you know. But we also talked about just the importance of also recognizing the humanity of people who are incarcerated. I think that's important, you know, the psychological, the emotional toll of being incarcerated and then just being beat down on. So maybe talking about, I don't know, that would be some sort of research. I'm not sure what, but then the other piece we talked about was just how prison is in and of itself a traumatic environment. So no matter what type of treatment, people can get the 5-star treatment, the greatest treatment wherever, but once they return back to the prison environment, because it is so harsh, it undoes all of the I think the great treatment, so to speak, that people are maybe subjected to getting outside of prison. So I those are some of the things that we talked about. And so I'll leave it there.
Thank you. And Dr. Ashkin?
Yeah, well, I had the privilege, truly mean it, of meeting Keisha's parents and her father, who is a really groundbreaking physician who has been championing the well-being of women and really way on the forefront of using buprenorphine, which I was talking about previously, for people that are struggling with opioid use disorder. And I was learning a lot about his experience, which is much deeper than mine, and the work that he's done. And I think it just really reinforces that we need policy change and we need advocacy. At the end of the day, we need people on the ground in diverse communities around our state, well, around our country, that will deliver care in a caring way, really to Craig's point, it's high quality, with and leave the stigma and bias behind. But I'm going to go back to Lauren's point that the institutional racism that defines medicine in many ways and is a legacy of medicine is unconscious. No matter how many unconscious bias trainings are done, it is prevalent, and so just I think it was just great to hear a community member who has been doing this work really probably on his own, and just to reinforce how important it is. And then I asked, what we should be studying, and he just brought up the really important point that at the end of the day, though, for advocacy change, and you get like HRSA, which funds the federally qualified health centers, to say, look, you have to have people with lived experience doing this work, that we have to have the evidence to be able to make that argument strongly, because at the end of the day, they are holding the purse strings, which do control what can be reimbursed at an FQHC, so what you can afford to do.
Thank you so much, and thanks for being in that conversation. So I wanted to open it up for any questions folks may have. We do have a little time on the call. Feel free to either raise your hand or, oh, I see you, Daquan. You can also put your question in the chat. Go ahead, Daquan.
Hello.
We can hear you. Okay,
first of all, thank you. I gotta say this. I appreciate y'all having this conversation. Doc, I appreciate you starting the NC Fit program. I'm down here in Wilmington, North Carolina. I work with Link. I'm one of the ones and I want to shout out my brother, Jamon Wells, down here, because he go hard for NC Fit. He probably get about 200-300 people to sign up for that thing. But anyway, one of the things that I wanted to address was something that I put in the chat was about the post-incarceration syndrome. I'm an individual who's been in and out of the system for over 30 years. I've been working with Keisha. I done worked with pretty much every organization across the state of North Carolina when it comes to advocating and organizing for criminal justice issues and social justice issues. But I'm someone who suffers from the post-incarceration syndrome, and I suffer bad from it. You know, I suffer bad from it. So because of that, for the past 2 years, even with the work I do, I've been shielding it. And I've been sweeping it under the rug and making it seem like it's good. So I've been researching. So because of my research and because of me working on being well with it and being able to cope with it, I have a support system. And a lot of people don't have that support system. So because of that, I've been researching and I've been speaking with Brother Craig about it. And I'm starting a campaign coming the beginning of this year, well, the first of this year, you know, really next month, on the post-incarceration syndrome, getting North Carolina to recognize it as a public health issue and not a public safety issue, because I've been to prison 4 times and I know people who've been to prison 5, 6, 7, 8, 9. I have a brother, and I'm gonna wrap this up quick. I have a brother who's been to prison 9 times and he just went back again. Anybody who's been in prison more than once, something is psychologically wrong with them. Anyone who wants to run, no matter what the situation is, I've been in some situations where I know desperate times calls for desperate measures because of our situations and the lack of opportunities. It's a lot of factors that leads up to post-incarceration syndrome and post-trauma things that you were dealing with, adverse trauma, health traumas, all of those things leads up to it. And what prison does is it exacerbates it. It puts you in a worse situation. And when you get in there, they're already looking at you. You come from an impoverished community. You already an aggressive person because of your upbringing. You come from the projects, boom, they put you in the worst prisons in North Carolina. You're going to go in there and you're going to get with the program. Not with the institution program, but the program of the prison. That doesn't make you a better person mentally. That's only going to exacerbate your issues. So when you do that, you bring those problems home, and we bring them problems back into our homes, our family, our sisters, our brothers, our children have to deal with this. The community have to deal with this. This is the leading cause for recidivism because there's no treatment for it, because it's not in the manual. And my job and my aim is to make sure that I get as much support as I can to be able to do that, to be able to get it recognized, because you cannot punish mental disorders. Simply as that. You have to look at a person's issues before you just, there has to be a factor in sentencing. And they say it is, but it's not. I'm telling you, I've been to prison 4 times. You know, I know what that's like. I done served over 30 years and now I'm not a light switch. I can't cut it off. I know I'm hypervigilant. I know I have anxiety. I know I'm paranoid. I know I have a very bad problem with authority. When it comes to any white man in a uniform with a badge, I'm going to be on 100 because that's all I know is abuse from you. Even if you're trying to be nice to me, I'm going to be because I don't know if you coming to harm me, to rob me to sleep or what, because all I know is abuse from you, from the prison system to the court system to out here now. You know, this is what we have to deal with, and that's something that I want to put a stop to and be able to bring awareness to. We don't want to go back to prison. We don't want to run to prison. We are not who y'all think we are when we do these things. It's not us. It's us acting in a psychological place where we put ourselves in because we don't know how to channel it and to cope with it no other way else.
A lot has to do with the trauma of living in prison.
And thank you for allowing me to share.
A lot of that, I think, has to do with just living in prison, Daquan. The trauma of living in prison.
Absolutely. It does, ma'am. You know, I've been to state 3 times and I've been to federal prison. I just did 12 and a half years in federal prison. And that put me in a whole different mind frame, because now you can be in North Carolina, you could be in California, you could be in here. I left the mountains where they treat you like they know who you are. I came home from West Virginia where they treat you and they gonna tell you in your face, ain't nothing you can do about it. And if you're a person like me, you go into the hole. You definitely go into the hole if you're not gonna sit here and let nobody scream and yell in your face. That's not rehabilitation. That's not how you rehabilitate nobody. You can't scream and yell in my face and tell me I'm not a man, I'm an inmate, and think that I'm gonna go home and I'm gonna do the right thing. Psychologically, I'm getting ready to buck the system. But what I'm doing is causing more harm to me, my family, and my community, and I really don't even know it. You know, and a lot of brothers and sisters are suffering from that. You know, I just want people to put that on their mind.
Thank you for always speaking your truth when we're meeting and on these conversations. And I'm so glad to hear that you are moving forward with this campaign, because I know it's something you've been talking about for a while. We continue to learn from you and learn with you, and I'm just grateful to be in the space with you tonight. And I know that we're gonna keep moving on this. So yeah, thank you again for that. Um,
And thank you for your support.
Thank you.
And I just realized that he said your mother and father was on here.
Oh,
And I want to thank y'all for raising this beautiful sister right here, because she has supported me throughout all of my trials and tribulations. When I said my support system, this sister right here has been one of my #1 supporters that has kept me from, she's opened my eyes to a whole different spectrum. And I appreciate that. It's people like this sister here while I'm on this call, you know, and I appreciate y'all for birthing and raising and bringing forth this true, beautiful queen. This my sister, my sister. Thank you for always support.
thank you, sir. Thank you so much.
Yes.
I wasn't sure if you were going to say something else, Dr. Wali, or if you're sorry. And sorry to cut you off, Dad.
That's okay.
Okay.
No, I'm good. I'm good.
I want to say something. How do I do that?
Okay. Was there another question or comment then? I wasn't sure.
Yes.
Yes, this is probably a comment, but also maybe a challenge, because I attend some national medical meetings, and I think that it's going to be really important for the culture of medicine to embrace the post-incarceration syndrome. I was looking it up, my wife was looking up, wow, and it's not a DSM listed condition. Yeah, so I'm going to see what we can do, and by educating more doctors on, let's push for this, because if we don't, then there won't be that piece of support that says, okay, this is a condition, let's prevent it like we do other public health conditions. You know, we went about stopping smoking, or trying to, because we knew the outcome of smoking was bad health. So let's consider stopping incarceration, because we know the outcome of that is going to be bad health. And I won't preach anymore, but this is what Keisha does to me. She makes me get excited about these topics. And so I have to speak my mind.
Doc, I love what you're saying though, Doc. And as you're talking, I'm thinking to myself, I think there needs to be more trauma-informed training for people in all realms of public life. And I'll just get real personal real quick with you. I was at the doctor the other week, and I'm waiting in the room for the doctor, and the door's closed, and I'm in the small waiting room for over 10 minutes. I eventually get up and just open the door because I'm getting very anxious, you know, and I realize it's the anxiety from having been in solitary confinement, having been living in cells. And so when the doctor came in, she asked why the door was open. And I explained to her, you know, about my experience. And she said, oh, I had no idea, you know. And so I think that people need, you know, in every realm of life need to be more aware of just trauma in general, but especially incarceration, because so many people in our society have been impacted by the carceral systems.
Thank you so much for those comments. Dr. Walik, while you are still spotlighted, could you just do one more plug for your petition? And we want to just make sure people know about how to support your campaign.
Oh yeah, thank you so much. So we started a petition for focusing, I think, aimed at Governor Cooper, as well as the Department of Adult Corrections Secretary Todd Ishii. And the petition is basically saying to them, that they need to end solitary confinement, and we, the citizens, are demanding that you end solitary confinement because we are paying for the torture that you folks are perpetuating in your system. You can find our petition by going to the Disability Rights North Carolina website. I'm trying to navigate my computer, but it's
Oh,
acting
and we have
funky.
shared it in the chat. We have it up
Oh,
here for you.
so it's there. Okay, so the petition is there. Yeah, once you go into the, I think when you find, what is it called? I think it's called criminal legal. You'll go into our work, and then from our work is one of the top campaigns, and from our work you'll go into the criminal legal. When you hit criminal legal, you'll scroll down and you'll see in solitary NC. And once you go there, you'll be able to access our petition, et cetera, et cetera.
Thank you so much. Thank you all, Dr. Ashkin, Dr. Wali, Dr. Brinkley Rubenstein for being here on this conversation. Thanks everyone for joining us. I know we ended up going about 5 minutes over, but it was such powerful conversation. And I know that with this group that there will be more action to take. Just want to know, in addition to the petition, that there is a resource with the new program that Dr. Ashkin started with the North Carolina Technical Assistance Center. And we also want to encourage you to sign our letter to the governor with our Decarcerate Now NC campaign. We are asking the governor to use his clemency power, usually around this time, this time each year since we started our vigil. The governor has exercised his power, and so we hope that you will join us in continuing to push him to do the right thing. I thank you all so much again, and we have one more community conversation next Wednesday that will talk about the new compassionate release law. And so we hope if you all are able that you'll join us for that one as well. Hopefully you'll receive an email with more information. As one more exciting note for us, we do have graphic note takers that capture the details of each of our community conversations. So you will see from us probably at some point in the new year a really nice visual of this conversation. And I hope you'll also be able to use that as a resource and take that with you as you continue your advocacy. Thank you and have a good evening.